Hello, everyone. My name is Jacob Alaichi. I'm a first-year master's student at HRM, and I'm really happy to be here to share some of the work that's been done at St. Joseph's Healthcare Hamilton, home of the Boris Family Center for Robotic Surgery. Specifically, I'll be discussing our findings relating to a recent advancement in the robotic platform, which involves the use of near-infrared fluorescence in robotic surgery for lung cancer. So my presentation will outline the context in which this research is being done and the aim of the study. Next, I'll briefly go through my research question and rationalize our methodology. And after that, I'll describe our results and conclude with interpretation of these findings and future direction. So lungs are made up of individual lobes. When a lung cancer tumor is detected in one of these lobes, surgeons typically perform a lobectomy. A lobectomy is a surgery most commonly performed for early-stage lung cancer and requires the removal of an entire lobe of the lung, which also removes a large amount of lung tissue. For patients with smaller tumors, saving as much healthy lung tissue as possible is important. So if you zoom in on the anatomy of the lung, one would find that it is further divided into pulmonary segments, and these can be removed instead to save a larger amount of healthy lung tissue. Now, there's a demand to perform segmentectomies over lobectomies to treat patients with early-stage non-small cell lung cancer due to the fact that improved screening technology for lung disease has been identifying a greater number of these cancers. However, the reason why lobectomies are still commonly performed in these patients, even though a segmentectomy would suffice as a tumor is still quite small, and when I say suffice, I mean suffice in making sure that there's adequate margins, is that the borders or fissures between segments, called intersegmental plane, are invisible to the naked eye, rendering the operation rather difficult and time-consuming. This operation is even more difficult in patients who require complex segmentectomy, and there is a learning curve associated to the procedure. To overcome this, medical research centers around the world have evaluated the safety and efficacy of using indocyanine green during segmentectomy to delineate the intersegmental plane under near-infrared fluorescence. This technique was initially described by Alaichi et al. In 2013. These studies found that the ICG is associated with a higher success rate and better perioperative outcomes than other methods of identifying the intersegmental plane. In the studies where ICG is used, the rate of visualization of the intersegmental plane lays between 80 and 90%, which is quite high. Other studies by Okusanya, Liu, and Matsura, all published in 2020, also show that the success rates of performing segmentectomies, regardless, still linger between 60 to 80%. So the aim of this study is to determine the utility of near-infrared imaging in the context of a learning curve and varying segment complexity associated with robotic segmentectomy. My research question can be posed as, in patients with early-stage non-small cell lung cancer undergoing robotic segmentectomy with near-infrared imaging using ICG to map out the intersegmental plane, does the distance between the predicted plane by the surgeon and actual plane delineated by ICG differ as the surgeon performs more cases? And second, does the added value of ICG differ between simple and complex segmentectomy? Now, the study methods are as follows. This was a prospective single-arm trial conducted between October 2016 and March 2021, and this is the clinical trial number. Eligibility criteria was patients who were above 18 years of age with suspected or confirmed clinical stage 1 non-small cell lung cancer or isolated metastasis that had peripheral tumors less than 3 centimeters in diameter. Lastly, preoperative CT scans confirmed that the tumor was isolated to one or more bronchopulmonary segments that were amenable to segmental resection. And the primary outcome of this study is the primary outcome of this study is a difference between the predicted plane by the surgeon and the actual intersegmental plane mapped out by the ICG. And to better illustrate this primary outcome, I have included this figure here. So our group have previously reported the feasibility and reproducibility of using indocyanine green during robotic segmentectomy to map out the intersegmental plane. After ligation of the corresponding segmental artery, vein, and bronchus, 2 surgeons examined the lung parenchyma and identified the intersegmental plane and marked it by electrocautery. Since the corresponding segmental vessels were ligated, after a few seconds of ICG injection, the dye will remain confined to this healthy section of the lung, while the segment that contains the tumor will remain dark. And that is where the intersegmental plane is located, right along the border between the green and the dark segments. In this figure, the red arrows outline what my primary outcome is, which is essentially the distance of the line below and then the distance of the line marked by the green here. So to remain in line with previously published reports on robotic-assisted thoracoscopic procedures for lung cancer, the effects of a learning curve were compared across temporal tertiles. The first tertile comprised of the first 30 cases, which is the minimum number of cases required to attain proficiency on the robotic platform. And the second tertile and third comprised of the remaining cases split evenly, meaning there were 75 in the second and 74 in the third. There were no significant differences in patient characteristics across each tertile. Segment complexity was determined prior to analysis and classified based on pre-existing definitions from the literature. And secondary outcomes that were included in this abstract are operative time, console time, conversion to higher order operation, which essentially mean that the surgeon had to revert back to a lobectomy or open thoracotomy, which takes more of the healthy lung tissue, and length of hospital stay. The statistical tests that I used were a Kruskal-Wallis test to determine differences in continuous outcome across tertiles, Mann-Whitney U test to determine difference in continuous outcomes between simple and complex segments, chi-square test and Fisher's exact test were relevant, and the level of significance was set at 0.05. So of the full series, 179 patients were included. The median age was 68 and 42.5% were women. 32 have never smoked, 95 were former smokers, and 52 were active smokers. In percentages rather, that's 17.9% who had never smoked, 53.1 were former smokers, and 29.1% were active smokers. And history of previous cancer was reported in 45.3% of patients. Now, the overall results, like I said, included 179 patients, and there were no significant findings in any of the secondary outcomes that were included in this analysis. The primary outcome is not included here because this is the number of patients in the full series and not all of them received ICG. More on that we'll uncover in the next slide. Now, deviations from protocol was the one significant finding that was observed, and it was that deviations from protocol to a higher order operation decreased significantly after surgeon completes the 30 cases required to attain proficiency. This suggests that surgeon's ability to perform segmental resection improves over time. Next, I did the tertile analysis for the patients that received ICG. Now, out of the 179 eligible patients who were enrolled in the study, 72 did not receive ICG, 58 of them because they did not undergo segmentectomy, and 16 because they received segmentectomy but without ICG since the intersegmental plane was visible. This leaves 107 participants that were included in the tertile analysis for my primary outcome. And this is where things get more interesting. Now, the distance between the true intersegmental plane and the predicted plane by the surgeon was shown to have decreased across tertiles. It was 20.65 millimeters, plus or minus 3.95 in the first, 2.13 in the second, and 1.49 in the third. Now, since the Kruskal-Wallis test doesn't actually outline the direction of this effect, I use a locally estimated Loess plot to try to map out in which direction this effect is going. And as we can tell, the distance between the intersegmental plane and predicted plane approaches zero as a surgeon performs more cases. The final set of analysis that I did was to compare these outcomes across simple and complex segments. Now, the average distance between the predicted plane and the true plane did not vary significantly between simple and complex segments. However, the operative time and console time did change, accounting for segment complexity. Complex segments had a longer operative time and a longer time on the robotic console than simple segments. Just as importantly, however, there were no significant differences in the median distance between the true and the predicted intersegmental plane. And that is important because it shows us that ICG does not discriminate between complex or simple segments when fulfilling its purpose of being able to identify the intersegmental plane. So to summarize my findings, overall, the surgeon's ability to perform segmentectomy improves over time. This was observed by the sharp decrease of around 20% in deviations from protocol after completing the 30 cases required to attain proficiency. The added value of indocyanine green diminishes as a surgeon performs more cases with ICG, which is shown by the decreasing distance approaching 0 between the true intersegmental plane mapped out by ICG and the predicted plane determined by the surgeon. There were no significant differences in the added value of indocyanine green between simple and complex segmentectomy, suggesting that ICG reliably determines the intersegmental plane in either case. Now, while the limitations of a single surgeon experience should be noted in our study, these are promising findings that are consistent with the current literature that looked at ICG in video-assisted thoracoscopic procedure. To our knowledge, this is the first one that looked at robotic uses of ICG and did a specific analysis for the ICG cohort. Actually, I will rephrase, maybe the larger trial that looked at robotic surgery. In the very near future, targeted segmental resections will become the norm rather than the exception, and thoracic surgeons should be at the leading edge of this innovation. The reason why these robotic advancements are something to look forward to in the context of lung cancer surgery is not because surgeons get to perform routine operations such as a lobectomy through, say, smaller incisions and with 3D visualization, but rather because it allows a surgeon to think of new ways to overcome problems associated with difficult procedures, such as a segmentectomy, that confer several more advantages to early stage lung cancer patients over the current standard of care. Thank you very much for your attention, and I'm ready to take some questions if there are any.